Good morning all. First of all, I would like to welcome our chairperson, respected Dr. Sholkar sir, and all the dignitaries here, all the faculty members who spend their time to be with us and discuss the case with us. So, to begin with, I welcome you all on the behalf of my department, the OBGY department of Maithili Medical College. Here is the structure of our department. We have got 8 professors, associates, and 7 assistants, and we have got 9 postgraduate seats annually. We are performing more than 3,800 deliveries, childbirths annually and taking care of them well. Recently, we are awarded for the highest number of tubal sterilization in private sector. This is the unit-wise distribution. We have got 5 units, 1, 2, 3, 4A, 4B. We are also conducting several programs like Jaipur Swasthya Charcha, in which our department is participating well. In association with the AGES, that is the Center for Gynae Endoscopic Surgery, we are performing more than 500 laparoscopic surgeries annually, including complex hysteroscopic and laparoscopic surgeries. Recently, we have organized Gynae Sonomila, a wonderful conference in the hospital. And finally, under the esteemed guidance of our chairperson, we are heading towards the robotics in gynecology. So with this, I start today's presentation. We have got one patient. She was 28-year-old female. She presented to us with her suffering, which she was suffering from 2 years with recurrent episodes of burning, micturition and haematuria. So how we dealt with this patient, how we managed, and what were the typical findings? We'll be discussing it later. So first of all, I would like to call up Charul, my third-year resident, to give you a brief review of the case summary and examination.
Thank you, ma'am. Good morning, dignitaries, senior faculties, and all my dear colleagues. Today, I am presenting a case of Mrs. X, a 28-year-old female, para to life 3, a resident of Bharatpur city, presented to us with chief complaints of burning, micturition off and on, passage of blood in urine since last 2 years, pain lower abdomen off and on since last 1.5 years. So patient was apparently asymptomatic 2 years back. Then she started having complaints of recurrent episodes of burning, micturition and off and on since last 2 years with increased frequency, that was 10 to 12 episodes in a day and 3 to 4 episodes during night. She also had complaint of urgency of urine, for which she had to rush to washroom. However, not associated with any involuntary passage of urine. She also complained of passage of blood in urine intermittently. Since 1.5 years, amount of blood was increased to the passage of clots, which aggravated during her menses. Blood was dark in color, mixed with urine throughout the act. It was not associated with any pain while passing urine. No history of urinary hesitancy or retention. She also had a complaint of pain lower abdomen off and on since 1.5 years. Pain was continuous, dull aching, non-radiating and non-progressive in nature with no aggravating or relieving factors. She took multiple antibiotic treatment with the local hospitals and was relieved temporarily. All her symptoms commenced after she had her second cesarean delivery 2 years back in 2022, during which she had bladder injury followed by repair and prolonged catheterization. Then she remained asymptomatic for next 30-35 days and started having above complaints. So patient didn't have any fever with or without chills, no colicky abdominal pain, loin pain, hesitancy, no foul smelling vaginal discharge, dysmenorrhea, dyspareunia, dysphagia. She didn't have weight loss, polyphagia or polydipsia, no easy bruisability, bleeding disorders or any anticoagulants drug intake. Coming to her menstrual history, patient resumed her cycles 5 months after cesarean section. During her menses, she only reported to have spotting for 4 to 5 days, using only 1 pad per day with regular cycles. It wasn't associated with any dysmenorrhea, and also she complained of passage of clots in urine during her menses. Her obstetric history is she is para to live 3. Her first pregnancy was a full-term LSCS in view of twin pregnancy. Her antenatal and postnatal period were uneventful. In her second pregnancy, patient had a lower segment cesarean section with sterilization 2 years ago in 2022. Intraoperatively, she had excessive blood loss and bladder injury. Bladder was repaired immediately, followed by prolonged catheterization. After removal, patient complained of dribbling of urine per vaginum, and following which she was recatheterized. After 15 days, she was able to pass urine normally. Patient also had history of pulmonary cause for which she took anti-tubercular treatment. The patient she is a homemaker and follows a vegetarian diet with normal appetites and normal bowel habits. Coming to her case summary, we have a case of 28-year-old female, para to live 3, with previous to LSCS, with history of bladder injury and prolonged catheterization, presented to us with burning micturition, passage of blood in urine, pain lower abdomen, with a scanty flow consisting of only spotting TD, with passage of blood clots in urine during menses since last 1.5 years, and no urinary incontinence. So now I would like to ask the audience what can be the differential diagnosis after the case summary. So we have a differential diagnosis of urinary tract infection, as patient has complaint of burning micturition, increased frequency, urgency, along with haematuria and pain lower abdomen. Urogenital fistulas, as it is correlating with her Obst history, as she had a bladder injury followed by prolonged catheterization and cyclical haematuria as well. Bladder endometriosis, as patient is young in age, presenting with cyclical haematuria with recurrent episodes of burning micturition, increased frequency, urgency and haematuria. Urolithiasis and urogenital tumors, as she also had recurrent infection, haematuria, dulling in pain as well. So going to her general physical examination, patient was averagely built, well nourished and was conscious, alert and cooperative. Her vitals were within normal ranges. Systemic examination was non-significant. Coming to her per-abdominal examination, only a old healed penetrative incision scar of previous LSCS was seen. There was no renal angle tenderness. In her gynecological examination, there was on local examination, we didn't find any excoriation or ulceration over the perineum. No stress urinary incontinence was seen. Her per-speculum examination, we didn't find any urinary leak or abdominal discharge or puckering or scarring of vaginal mucosa. In her per-vaginal examination, everything was normal except we found a round mass of around 4 into 4 centimeters, regular margins, smooth surface, cystic in consistency, and was mobile and could be felt separate from the uterus in left adnexa. And there was no nodularity or tenderness in the posterior fornix. Her rectal exam was also no thickening or nodularity seen in uterosacral ligaments. So, after examination, we have a 28-year-old female with burning micturition, passage of blood in urines, pain lower abdomen with passage of clots during menses. Her general physical and systemic examination was normal. In gynecologic examination, we only found left adnexal mass. There was no visible urinary leak, no fistulous opening on TS examination. So, revisiting the differential diagnosis, we couldn't eliminate any of the differentials. We could only add up to the adnexal mass as an additional finding.
See, whenever you have a normal bleeding through any orifice, it becomes a sinister sign. And therefore, you have to consider more common causes of it. Here, she is passing blood in the urine. That becomes the symptom. Rest are all associated symptoms. Urinary tract infection, unless it is very severe cystitis, will not cause gross haematuria. Similarly, a pure urogenital fistula will not cause haematuria. So, if haematuria is the predominant symptom, you have to consider causes, and since you said there is a relationship with the cycle, you have to put bladder endometriosis as the first. She is young, otherwise you could have put up urothelial malignancy as the second. If the listing of differential, this is all right for a theory paper, that these are the causes of these symptoms. In a clinical exam, you have to put the most important or the most relevant differential diagnosis first.
One small point about the presentation. When you're presenting a 8-bullet list of findings and there is no positive finding, that should be highlighted so that nobody misses that. Now this round space of imaging which you found in the examination, I think that's the only positive finding. That should be highlighted either in bold or in shade of color. But you wanted to
Sir, we have, sir, can I ask? Sir, basically the question that was addressed first, we have kept the diagnosis first as infection because initially the hematuria was slight. It was associated with burning micturition, patient was catheterized for long. So we kept it first. And looking at the Obst history of the patient, that she had history of bladder injury, prolonged catheterization, hematuria was cyclical. So that's why we have kept it first. Otherwise, there was no history of renal pain, loin pain. So we kept the diagnosis of urotheliasis, urothelial tumors. So looking at the gynae perspective, we kept the diagnosis first.
I think they have taken an excellent negative history. So going by the negative history, the differential diagnosis sequence is acceptable. Good.
After this, we ordered some investigation for further confirmation. Her hematologic parameters were within normal range. In her urine analysis report, we found 20 to 25 WBCs, 2 to 3 RBCs. Bacteria was positive in the microscope. In culture insensitivity, we found E. coli 10⁶ colony forming units per ml. After blood investigation, we advised for the radiological workup that included ultrasound whole abdomen and pelvis, CT urography, hysterosarcomography. To discuss this further, now I would like to invite Dr. Diksha for the radiological findings.
When was the urine sample taken? During hematuria or
When she came
RBCs
to
are
us,
not telling with the gross hematuria history?
when she came to us, she was her LMP was 15 days back. So at that time, he was not having gross hematuria. That's why.
Good morning, respected faculty. Good morning, respected faculty, seniors, and my dear colleagues. Today I, Dr. Diksha Ahlawat, will be discussing the imaging findings of our patient. Before I proceed with discussing the imaging findings, I would first like to discuss the normal anatomy. In figure A, we have a normal transvaginal ultrasound in the sagittal plane. Here we can visualize the anechoic, minimally distended urinary bladder anteriorly and the uterus posteriorly. The side of the uterus that faces towards the urinary bladder is the anterior side, and the side that faces away from it is the posterior side. So here we have the anteverted anteflexed uterus with the fundus here, the body of the uterus here, the lower uterine segment, and the cervical canal. Now proceeding with the imaging findings in our patient. The patient had a hypoechoic focal defect in the posterior wall of the urinary bladder that extended till the serosal surface of the uterus. This raised the suspicion of the possibility of a vesicouterine fistula. On scanning the remainder of the hemipelvis, we observed a dilated tubular structure with echogenic internal septations in the left adnexal region, suggestive of a left hydrosalpinx. The remainder of the transabdominal scan showed the kidneys were normal. There was no evidence of urolithiasis or urothelial tumors. So the next investigation that was performed to further evaluate the tract was CT urography. Here we have the axial section of pelvis at the level of hip joint, showing the skin and the subcutaneous tissue all around, the rectus abdominis muscle anteriorly, the gluteal muscles posteriorly. We can visualize the urinary bladder that contains contrast mixed urine. Posterior to it we have the uterus and posteriorly the rectum. Here is a mid-sagittal section showing the lumbar vertebrae, the pubis bone, the urinary bladder, the anteverted and anteflexed uterus, and lying posterior to it, the rectum. We can observe a hypodense tract that is extending from the posterior wall of the urinary bladder towards the endometrium. We can appreciate this better on this sagittal section, where we can see that the tract is arising from the posterior superior wall of the urinary bladder and going till the lower anterior segment of the uterus. However, we could not observe any extravasation of contrast from the urinary bladder into the endometrium. Thus, we could not prove the patency of the tract, nor could we differentiate between a sinus and a fistulous tract here. So the next investigation also, there was a dilated tubular structure in the left adnexal region suggestive of a left hydrosalpinx. So to evaluate these things further, the next investigation that was performed was hysterosalpingography. To perform the test, the iodinated contrast was passed through the cervical canal into the uterus. The films were taken immediately and a customized oblique view was taken. Now, as compared to CT urography, we could not, owing to the thick myometrium and the obliquity of the scar defect, we could not observe any retrograde movement of contents from the urinary bladder into the uterus. But when we performed HSG, we could observe the clear passage of contrast passing from the endometrial canal through the fistulous tract into the urinary bladder. This showed the one-way flow through the tract and also emphasized the importance of performing HSG in such patients, where we can clearly see that the contrast filled the urinary bladder and justified the clinical symptom of cyclical hematuria in this patient. Thus, radiologically, our diagnosis was of a vesicouterine fistula. Now I would like to call upon Dr. Charul to discuss the further management of the patient.
So after radiological imaging, we eliminated bladder endometriosis as patient was young in age and we didn't find any nodularity or thickening of the intrasacrals on pervaginal perrectal examination as well as in radiological findings. We also ruled out urolithiasis and urothelial tumors as her ultrasound and CT urograph were clear. Lastly, we ruled out vesicovaginal fistula as no fistulous opening or was seen on first speculum examination and no fistulous tract was visible in the imaging. So we got the diagnosis of urinary tract infection with vesicouterine fistula and adnexal mass, which was later confirmed as hydrosalpinx in the imaging. So we have a 28-year-old female para to life 3 with previous to LSCS with vesicouterine fistula with recurrent urinary tract infections and left hydrosalpinx. To discuss the case further, now I would like to invite Dr. Kalpana for further discussion.
So with this final review of the patient, we'll be discussing first what is this entity, what we are dealing with. Basically, it's a fistulous communication between two organs which has got different structure, the function and the capacity. Our uterus is a muscular organ that doesn't have a potential space, while the bladder has got the capacity to expand. So all these features make this fistula a peculiar one. The intrauterine pressure is always better, is always higher than the bladder pressure. Another thing is the internal cervical os. Like below, if you see here, we can see the lower portion of the uterus, we can say. This is the internal os, this is cervical canal and this is the external os. So if the fistula is lying above the internal os, we have got the sphincteric action of the internal os and the resistance of the cervix. If it lies lower down, then the resistance of the internal os is gone and we have the resistance of the cervix only. And if the fistula is further lower down, then the resistance are even less. So the chances of going blood from uterus to bladder, they are increases as the fistula goes down. They decrease as the fistula goes down. So in type 1 fistula, the fistula is lying here, above the internal os. So the sphincter of the internal os is intact. It doesn't allow your menses, the menstrual blood to go inside the vagina. It goes directly into the bladder, and the patient presents with cyclical imaging. If we go down, like type 2 fistula that we had in our patient, the fistula's opening was lying here, in the upper part of the cervix, below the internal os. So here the menses was coming below and it was going part into the bladder and part into the vagina. Type 3, the fistula lies lower, then most of the menstrual blood goes down and it never goes into the bladder because the sphincteric action is going down. This was about the flow of the menstrual blood. What about the flow of the urine? So in type 1, because the fistula's opening is lying at the top, the sphincteric action is intact, so urine if even enters into the uterus can never go down. So these patients are absolutely continent. In second variety, the fistula's opening is lying here. So you may say that there might be incontinence as well. But what happens that there is some tissue which is clogging the opening of the fistula's uterine side opening, then it can prevent the leaks. So presence of urinary incontinence is variable in these patients, in type 1 and type 2. In our patient, we had type 2 fistula because the fistula's opening was lying in the cervix. So our patient was passing menstrual blood from both the sides. She was having spotting during menses and she was having heavy bleeding from the urine at the time of menses, but she was not incontinent. So with this background, I'll lead you to the management of the patient, what we did. We did a PAC workup to the PAC fitness. We took a written informed consent after explaining the patient about the psychouterine fistula, what it is and what we are going to do. Because the patient was very well with the taking treatment again and again. We have to expose the patient to a major surgery. So we explained him about the procedure, planned surgical procedure, need for prolonged catheterization, long-term follow-up, and finally we took the urology reference to help us in the cystoscopy. For that, I am thankful to Dr. Manish Gupta sir, and I would like to call Dr. Rahul to further proceed with the findings of the cystoscopy. So what we are going to do, we'll do cystoscopy, we'll catheterize both the ureter to safeguard them during the surgery. Then we do hysteroscopy. After that, we'll cannulate the fistulous tract, dissect the bladder and the uterus and excise the fistulous tract. We'll close the bladder and the uterine defect and finally interpose an omental graft to prevent better healing and avoid recurrence.
Good morning, respected dignitaries, senior faculty and my fellow colleagues. Before starting the video, I'd like to give an overview of the cystoscopy which was performed. So for cystoscopy, the cystoscope was introduced and initially we saw the urethra which was normal. The bladder neck was visualized, that was also normal. Then we looked for both right and left ureteric orifices. They were also normal. Bladder was thoroughly inspected and the bladder wall mucosa was normal. Fistula was seen on the posterior wall of bladder which was approximately 5 to 6 centimeter from the left ureter and around 4 to 5 centimeter away from right ureter. So now I'll start the video so you can have a brief idea. So, as I've explained before, now we're inside the bladder and what we are seeing right now is the fistula, which is approximately 5 to 6 centimeter from left ureter and from right ureter it's around 4 to 5 centimeter. Now the right ureter is identified and we will do ureter catheterization by placing a guide wire. And in the similar fashion, left ureter was also ureter catheterization was placed and it was safeguarded for the operation. After after safeguarding both the ureters, the fistula on the posterior wall, we also placed the guide wire. So during surgery, it will help us detect. After this, hysteroscopy was performed by the gynecological department. So I will call back ma'am to explain regarding the hysteroscopy.
So now we proceed with the hysteroscopy. This is the external os. We are heading towards the. Yes. Here I will pause the video for a bit because we have to concentrate on the location of the fistula. I said it is type 2. That means that it should be lying below the internal os. So here we will be seeing that. This is the external os, and we are heading towards the cervical canal. In a while we will be able to see the cervical rugae. The cervical rugae will be taking us towards the internal os. We are heading inside, but what we see? We see an opening. That was the fistulous opening. So first we encountered, after entering the cervical canal, we encountered the fistulous opening first. This is the fistulous opening that will lead us towards the bladder. But we have to go to the cervix, internal os. So we change our direction, we follow the cervical rugae, and it is taking towards us towards the internal os. So now we are heading towards the internal os. This was the guide wire which we have passed through the fistulous tract. Now it has come inside the uterine cavity. So now we are entering the uterine cavity. So this shows that the fistula was lying in the cervical canal below the internal os. It is type 2 fistula. Now we are grasping the guide wire and taking it out to the cervical os. So, and then we threaded a ureteral catheters over it to cannulate the fistulous tract. So while dissecting, we can locate where is the fistula. Now we are heading for the laparoscopic picture. This is the primary view. Because she was a case of previous two LSCs, there were omental adhesions that were lysed. This was the left adnexal mass that was proved to be hydrosalpinx. It contained a clear view. We drained it and later we removed this. So this was an incidental finding. Now we are locating the site of the fistula. So since because of presence of fistula in previous two surgeries, there were dense central adhesions, we open the peritoneum, then we take the lateral window approach. Because in surgery it is said, when you find the adhesion, don't face it directly. You go from the non-adherent area, come from lateral side and then make the adhesion into a point adhesion and then cut it. So we are taking the lateral window approach. Now we are dissecting the bladder. Here you can see the bladder. I am holding it with the grasper and I am dissecting anterior to the uterine artery because bladder lies anterior to the uterine artery. This is the fistulous tract that we have seen. Now we have deliberately opened the bladder because we have to dissect the bladder from the fistulous opening. This is the principle that we have to dissect both the areas apart. If we just dissect them and suture them, then again both the suture line will stay in close contact and again the fistula will form. So we are dissecting from one side to the other. This we have opened the bladder was opened, this was the anterior flap. Now we are dissecting the posterior layer of the bladder from the fistulous side. You can see here is the bladder. And gradually we will be achieving more and more distance. This is the bladder. And from here we can see the ureteral catheters that we have inserted, that they are far apart and they are safe. This is the UC that we have passed, cannulated through the fistulous tract. So here is the bladder, we have separated apart, this is the uterine opening. Now we have to close the uterine defect, but we have to keep in mind that we should not be closing the cervical canal. For that we have kept a stent inside the cervical canal and we are putting sutures over it. Then we are doing with the vital number 1. I am very thankful to our team cages, Dr. Nahata sir, Dr. Farid, that those helped me a lot and pushed me to do this surgery and gave me confidence that I can do it. Now I am proceeding with the bladder closure. We are using 3-0 V-lock and doing full thickness closure. Dr. Manish Gupta sir was there to help me out and he was guiding throughout how to close. So we are taking full thickness bite. taking this V-lock suture here makes the surgery a bit easy because it avoids the need of knotting. Secondly, it gives an equal tensile strength throughout the suture line, so it gives a better healing. So here we are closing. So we should do a full thickness closure and we should not leave the edges, you can say the margins, because otherwise they can cause a bladder hematoma later. Simultaneously, you can see I am not tightening the sutures, because if I tighten simultaneously, I will not be able to see the further edges. So I am keeping them loose and later I will tighten them. This is the final closure of the bladder. Now we are checking, I will check the watertight closure of the bladder. I have refilled the bladder with the saline. And it was watertight, and then we put an abdominal drain. So now in the post-op period, we put the patient on post-op antibiotics, bladder relaxant, because the bladder, it will promote the healing of the bladder. Ask the patient to put lightly of liquids. Catheter care was done. That is very important. We should take a check that the catheter should be draining continuously. It should not block. And it should be, proper hygiene should be taken care to promote healing. Because sometimes what do? The injury is repaired. But because of not taking care of the injury in the post-op period leads to failure of the surgical repair. That is very important. That is very important for the purpose of PGs either. They should know that every fistula has to be dealt, which is dealt in the surgery, has to be taken care in the post-op as well. Then her menses were stopped for 3 months by giving her OC pills, because otherwise if she bleeds, it will again lead to impaired healing. Catheter was kept for 21 days and it was removed. She passed urine normally. After 3 months, when we stopped OC pills, she resumed her menses and there was no menonuria or bladder symptoms. We have got 6 months follow-up with the patient and she is asymptomatic and she is doing well. So, to review the literature of this entity, I would like to call Dr. Maithili on the stage.
Thank you, ma'am. Good morning, respected dignitaries, my senior faculty, and my fellow mates. I will be just briefing the review of literature. Vesico-uterine fistula is one of the least common types of all urogenital fistulas, accounting for only 1 to 4% of all the cases. It was first reported in the literature in 1908 by Naif. However, it was first described by Dr. Muhammad Abdel Fattah Yusuf, an Egyptian obstetrician, in 1957 as a clinical syndrome also known as Yusuf's triad. The triad consists of cyclical hematuria, amenorrhea and complete urinary incontinence in a patient who had underwent lower segment cesarean section. Coming to the etiology, various risk factors attributing to vesico-uterine fistula are obstructive labor, traumatic vaginal delivery, improper use of instrumental deliveries, repeated cesarean sections, placental accreta and creta percreta, and other factors which can lead to this are endometriosis, inflammatory bowel diseases, migration of IUCD, intrauterine contraceptive devices, bladder tuberculosis, and radiotherapy for any carcinoma cervix. Lower segment cesarean delivery is the single most common cause of vesico-uterine fistula, approximately 83 to 93% of all cases. Currently, the main cause is it only, and these injuries occur 2 times more after repeated cesarean sections. Coming to the clinical presentation, they can present variably to us. If it is an early presentation, they can come with haematuria, repeated urinary tract infections. And if it is a delayed presentation, they can come with recurrent UTIs, secondary amenorrhea, secondary infertility, chronic pelvic pain, cyclic hematuria with or without urinary incontinence. The urinary incontinence can be variable subjecting to the level of the fistulas and also the competency of the cervix as a sphincter. The patient can also come with comprehensive urinary leak which can impact the sexual function, ability to conceive and also the social life. So a non-specific clinical presentation with negative examination can delay the diagnosis. Coming to the treatment options, And there are various modalities of options like conservative and surgical management. But the choice of treatment depends upon the patient preference and also on the size and type of the fistulas. Coming to the conservative management, is ideally preferred in small fistulas. The expected management is basically with the bladder catheterization for almost minimum of 3 weeks, but can be over for a period of 4 to 8 weeks. And amenorrhea, induced amenorrhea can be achieved with oral contraceptive pills, progesterones, or gonadotropin releasing hormone analogs. For almost there has been various studies in which this treatment was applied, and for almost 6 months the patient resumed. But the success rate of conservative management is only 5%. As stated in earlier studies, we can also go for cystoscopic fulguration for small fistulas. Coming to the surgical treatment, it is still the mainstay and definitive treatment of a cycloutrine fistulas after cesarean sections, because it is done generally for bigger fistulas, larger fistulas in a delayed presentations. It is what we have to do is either the excision of the fistulous tract and repair of the defect, and transposition of omental grafts between the uterus and the bladder for better healing and to prevent recurrence. Now I'd like to call upon the stage Dr. Kalpana ma'am to further conclude the case. Thank you.
So why we took this case? Because it's a famous term that the eye sees only what the mind is prepared to comprehend. So a very good clinical history and a clinical knowledge will allow you to think out of the box, to believe what is not visible. That's why we took this case, and that is very important message for the PGs, that they should spend time with the patient, take proper history, and even if they think that there is something wrong, then they can confirm with the modalities, imaging modalities, and the more important thing that they should give clinical history to the radiologist. Sometimes we just write the paper that this investigation should be done. In this case, this helped us a lot. I talked to Niharika ma'am that you have given the structural defect. You have not told that the dye is leaking from this side to this side. Then how I should be confirmed, and how should I should pose the patient for the major surgery. By doing surgery unnecessarily, I might induce an incontinence to her. So then she gave me an idea that we can customize the HSG and we can take the help of the imaging further. So with this, I would like to end this session, and I open the call for the questions.
Well, one very general question. Is this a gynecologist area of the surgery or a urologist area of the surgery?
Sir, basically anybody can do, because we are taught in our gynae teaching also to deal with the fistula. So if we have after experience, we can deal with, and in the medical college we have got the help of the concerned department, so we can take the help. So otherwise it's not, we are not able to do. We are taught that.
Why did we not opt for a trial of conservative treatment? Why did we go for surgery straight?
Because conservative management usually helps in small fistula which are diagnosed earlier. If the diagnosis is delayed or the fistula is large, if the diagnosis is delayed, it leads to epithelialization of the fistulous tract. So once it gets epithelialized, then the chances of conservative management giving us results are very less. So that's why we took this patient for the surgical management, because she was apt for that. Yes.
Non-academic medical legal comment. In the operation notes, is it documented that the urology team was there?
Yes, sir, it is mentioned.
That's very important. See, if things go right, nobody questions who did the procedure. When things go wrong, especially in a big institution like this where all specialties are available, the first question asked will be why the concerned specialists were not employed. So it is very, very important that the moment they are crossing the border, we must have the other team there, and it should be documented.
Sir, this kind of surgery is basically combination of both gynecologist and urologist surgery. This is the second case we have done here in our institution. And firstly, it was done in urology department where we took help of the entire gynecologic people. And this is the second case where gynecologists took help of urologists. So it's a combination case.
one more non-gynecologist question. One more non-gynae, non-surgical question. Is this because of suboptimal cesarean section, or is it a normal complication of LSCs?
No, sir, it is not a complication of LSC, it's not a normal complication because cesarean is considered a very safe surgery. So we have to take the risk of the patient, that what are the risk factors. According to, we have to apply our clinical judgment or our surgical steps. So if you do adequate bladder dissection and well mobilize the bladder, sometimes what happens, the patient is taken obstructed labor. The bladder is not dissected, the obstetrician is in a hurry to take out the baby. And he or she has not dissected the bladder. And while retrieving the baby out, the lower segment gets, you can say, torn. In that, we don't find the edges. So it's always advised, do a dissection prior. Dissect the bladder prior. If we are dealing with the placenta perfecta and preterm, then we have to dissect the bladder prior and take out the baby and then proceed with the section. If we make the field messy, then it becomes very difficult for anyone. Even for not for a gynecologist, for a urologist, it becomes very difficult to clear the things up. So it is always advised to do the dissection first and then proceed with this. So this is the testimony of the patient. This is the patient. We are